This is a hospital, and why don't you skip next? Next slide. Malalignment occur. Everybody know. Next. Okay, achondroplasia occur 1 per 10,000, and lysomelic dwarfism. And regarding genobarbital deformity, already Dr. McKenzie described about the degenerative arthritis occur very rarely. Most of patients, knee and ankle pain. This is 14-year-old, this 49-year-old patient, and bifocal osteotomy was done. And the usual indication is the knee and ankle pain due to deformity. Only 17% required osteotomy for symptomatic malalignment. Also, longo fibula is also the pain per site. I reported this mechanical axis deviation due to longo fibula, because if you see the center of femoral head to center of femoral ankle joint, the conventional MAD, but I measured from center of head, center of foot because of longo fibula, and then more severe mechanical axis deviation was visible. And this tibial calcaneal angle is important to measure collection amount of heel bearers, not only distal tibia. You have to consider subtalar, the joint contracture, compensation or not compensation. Also, achondroplasia has the three-dimensional deformity already mentioned. Hip coxavara with the sagging lupus sign here. Also, distal femur ankle deformity. We also measured the rotation deformity in CT. We found increased acetabular anteversion and the femoral anteversion, or decreased tibial external torsion. And there are many papers about the limb lengthening of achondroplasia, but there are few papers about complication. They don't want to expose complication. And then also there is no paper about quality of life after limb lengthening. And my patient at 12-2, they underwent bilateral tibial lengthening and bilateral femoral lengthening. This is frame for monofocal tibial osteotomy or bifocal osteotomy. Tailor frame is expensive in Korea, not available. Medical insurance committee don't allow to use high expensive tailor frame. And this is femoral lengthening with a monofixator. This is 10 centimeter done, and 20 centimeter was done. And my question is, what is the rate of complication? Is there any correlation between complication and quality of life? And we classified complication like this problem, obstacle sequelae, and bony complication and joint complication, or several questionnaire. And we had many complications, 79 complications. And the total length is 10 femur and 9 for tibia, and healing index 34 to 35, and joint complication occur for 45%. Bony complication 41%. This is echinus deformity and hip flexion, knee extension, and lumbar lordosis after lengthening. Regarding contracture, echinus deformity, PT, or recession, or foot frame can be applied. I reported this occurrence echinus if patient had total tibial lengthening more than 40%, including distal tibial lengthening 15%. All of patients has echinus deformity. That means distal tibial lengthening should be minimum or just the deformity collection, because Achilles tendinous part is very difficult to stretch. And this is the case with hip flexion contracture and knee extension, stiffness, and lumbar lordosis, and treated rectus femoral release, tensor fasciae lata, and sartorius. Sometimes quadriceps plasty is necessary. And then we had many hip flexion contracture and refracture of femoral shaft fracture. More than 50%, you can see here, high incidence of hip flexion contracture and then refracture of femur. And we reported this result, and bony complication, varus deformity and refracture here. And this patient had varus deformity and hemiepiziodesis was done, and then simultaneous femoral lengthening was done, and then refracture occurred. I'm nailing this side, left side, we had very complication. This is a case with refracture, because you can see very central and concave callus formation after removal fracture. and then flexible nailing and bone grafting was done. And then I recommended when you see the very severe, very narrow callus formation, central, lateral, concave type, you have to compress until fusiform or cinder callus is visible, and then you have to resert. Another problem is growth arrest. I reported Pfizer growth arrest for tibial lengthening of chondroplasia, and then I found, because many patients 20 centimeter lengthening, but the patient told me, where is my 3 or 4 centimeter? And then I have to explain, but I could not understand why 4 centimeter lost after lengthening. Then I found I reviewed the all X-ray until skeletal maturity after tibial lengthening and femoral lengthening, and we found that the growth rate decreased. And then we extended this study for tibial lengthening and femoral lengthening, and then we measured the length after skeletal maturity. Also, we made a scoring system, Pfizer arrest, because of increased joint press, Pfizer closure occurred earlier. You can see here. And then after tibial lengthening, only two femoral lengthening and tibial lengthening, totally almost 8% lost because of growth arrest or partial arrest. And then I can explain the patient. Most of the patients underwent this patient 80-year-old. 12-year-old patient decreased, the growth lost is a little minimum, but 80-year-old, 20 centimeter lengthening, the compressed physis, and then we have decreased growth rate. What about quality of life? We reported this questionnaire, limb lengthening is appropriate for chondroplasia, and there is no difference AOS and SF36 score between non-surgical group and surgical group in achondroplasia. However, Rosenberg's self-esteem score higher in surgical group. And you measure the many things, tibial lengthening after femoral lengthening. A little bit pain, but disappeared during long-term follow-up. SF36 also score same. However, Rosenberg's self-esteem score increased. That means after lengthening, patient has higher self-esteem. I want to emphasize a lot of people during tibial lengthening. You can see this only distal tibial fibula joint fixed, and then distal migration of fibula occur. And many also recommend only proximal, distal, or proximal and distal. And then I reported also investigated effect of distraction resist force. Many complications due to lag effect of fibular distraction. I neglected many, I missed the fibular amount of distraction. And then we measured the lengthening amount of tibia and fibula and migration of fibula or axial deviation. And also we reported this result in 2009, and then we found the distal migration of proximal fibula here. And then we found the more than 25% patient has more tibial fibula distraction difference, also distal migration of proximal fibula or tibial varus deformity. Also, we had the second study for 100 tibial lengthening, and then we reported fibula-related complication. And then there are many complications related to fibula. You can see premature consolidation, delayed concentration, and varus of knee and fibula angulation. You can see this X-ray. This X-ray is showing this patient had fibula osteotomy here, but the premature consolidation occurred. And then during lengthening, patient had pain and knee flexion contracture. And then I missed because of this ring height of fibula. And then we found the migration of fibula here, cut through the proximal fibula head. Because during 10 centimeter lengthening, very thin fibula cannot resist the wire cut through. And then I performed the fibula osteotomy and then insert hairpin and proximal transport. However, still the residual distal migration or hemiepiphyseal. Sometimes it could help for lateral thrust or lateral ligament laxity. Another case is you can see the people are here, but the pies are separation here, a lot of this. And patient also complain of knee pain, but I didn't catch this. And then the osteotomy here, fibula, and then hairpin insertion and proximal transport was done. This is a final case. This is another case of the proximal migration of distal fibula. You can see here, proximal migrated because of the premature consolidation, and then we cut the bone and transport distally, and then you can see here we restore the ankle motis here. Another humeral lengthening already mentioned here. Hygiene care is impossible here, and then we lengthened the humerus, and then we compared the complication between upper and lower limb. And we found the high rate of callus formation, low complication rate in humeral lengthening. Also, we measured the complication rate for femur 0.8, humerus 0.8, femur is more complication. Also, pixel value ratio also different. Quality of life increased. In conclusion, more stiffness patient had more than 30%, and callus shape already mentioned.